गॅटरिंग विचार हा नाही त्याचा कोई नहीं, मेल करे, फोटो भेजे सब। ठीक। Anand,
जी प्रणाम सर।
I think it is 7 o'clock.
जी जी जी।
Shall we
Yes.
start, sir?
I think we should start our class now. We are doing very well, very well. Dr. Senthil Kumar, start your class today.
Thank you, sir. So, very good evening to one and all. Today, we are going to see how to approach bites and stings in the emergency room. So, this will be more on case scenarios. So, you can just imagine that you are in the emergency room. So, this is a 12-year-old male boy, okay, brought to the emergency room. The history of dog bite. It is a pet dog. Actually, he is a son of a superintendent of police. They have a Rockfiller dog next to their home. That Rockfiller, he goes and play with the Rockfiller dog. The Rockfiller dog is vaccinated, but still it bitten the boy. So what do you want to do now? Wound care, rabies vaccine plus TT, or option 1 plus prophylactic antibiotic, or option 2 plus rabies immunoglobulin. So which you prefer? Can you put somebody in the chat, please? ARV, immunoglobulin, TT, and antibiotics. Okay, this is option 2. Option 1. Anyone? Any other? Actually, here option 3 is the right. Why 3? Good question. So, in a post-exposure management, we have 3 steps. Okay, first step is wound cleaning. Second step is passive immunization. If you are using human rabies immunoglobulin, it is 20 international unit per kg and the maximum of 1500 international unit. Step 3 is vaccination. We have 5 doses. It should be given as an intramuscular. Okay, in the days of 0, 3, 7, 14 and 28. When we are giving the first dose is 0. It's not a bite day. Okay, it has to be remembered. So, which category it's there? WHO has classified into 3 categories. Category 1. So, touching or feeding an animal, licking by the dog on the healthy skin with no open wound. No documented contact of dog saliva in the mucous membrane or any other thing. then it is a category 1. What we can do is just you can observe this patient. No need to do any other further intervention if the history is very reliable. Okay. Category 2, so nipping of uncovered skin, licks on the broken skin, or superficial scratch that does not break the skin. You have to administer vaccine immediately. Okay. So vaccine, as I already told, 0, 3, 7, 14 and 28. 5 doses has to be given. Category 3, if there is a single or multiple transdermal bites or scratches which penetrate the skin, licking over the mucous membrane, then you have to administer rabies immunoglobulin and vaccine immediately. If your center does not have rabies immunoglobulin, then what you can do is you can administer 2 doses of vaccine on the day 0 and ask the patient to put as early as within 72 hours the immunoglobulin can be given. So this will protect the patient for further prevention of rabies. As you well know that by biting itself, the rabies virus will not enter into the human body. This virus slowly enter and during the incubation period it goes. So in this patient, can we do a primary closure? Can somebody put? Can we do a primary closure? No. You want scar to be very ugly? Can be safely done after adequate infiltration of local infiltration of RIG? Should be never done. What are 3 options are there? Which you prefer? Two. Okay. Any other better answers? If there is no cosmetic reason involved, then you should not do the suturing. If there is, you want to do a cosmetic part is involved, then we can do. Okay, surgically, if unavoidable, minimum loose sutures can be applied after adequate local treatment along with proper infiltration of RIG. I am one of the panel member for the National Institute of Communicable Disease, where we formed these guidelines based on the various other brainstorming roundtable session with the expert. Then we came to a conclusion. This is another case. A 34-year-old gentleman comes to you to the emergency room. The history of dog bite 1 month back. Grade 2 dog bite in the leg. Patient received tetanus toxoid. Not vaccinated. What do you want to do? Give RIG, ARV. Give ARV alone. Don't give anything as nothing will work now. What is your options? So 2. Majority of people are saying 2. Why? Why not you give RIG? So it will give immediate immunization to the victim. This is the incubation period. So majority of dogs, within 30 days, only 25% of rabies virus enters. 30 to 90 days, 50% enter. 90 days to 1 year, 20%, and more than 1 year, it is 5%. Okay. So be cautious, very, very cautious. Even after 30 days, there is a beneficial by giving ARV. There is no side effect. So better you give ARV for the protection. So this is one of the late press paper news saying that NIMHANS has confirmed a first case in the world that man dies of rabies after 25 years of dog bite. The very remote history. Okay, this was treated in the Goa. The patient was from Goa, came there, treated and identified all the classical symptoms. Then the patient died. Biopsy clearly proven the Negri bodies. Okay, so even after 25 years, there is a remote chance of getting rabies. So adequately, we need to immunize the patient. Certain do's should be done when you are managing the rabies, the dog bite patients in your ED. Intramuscular injection should not be given in the gluteal region. Only the deltoid region should be given. 0 day is the first dose and not the day of exposure to the dog bite or the rabies virus. There are many times the patient would have been already vaccinated with the 5 doses of vaccine. Then again the patient comes. If the patient is healthy individual, immune competent, then you no need to give RIG even the patient has category 3 bite. Okay, you can give only 2 injections, 0 and 3 is sufficient. But if the patient is immunocompromised, that is, patient is on hemodialysis or chronic steroid therapy or any other immunosuppressive or uncontrolled diabetes causing various other infection, it is better to give 5 full dose including RIG. The new thing is now from 5 dose of post-exposure prophylaxis, they reduced to 4 dose, that is intradermal. Okay, instead of intramuscular, they have done intradermal. So this will help you out when you are doing a mass campaign, intradermal. This is called as PI protocol. This will help you to reduce the vaccine. These are the various questions we regularly get from the general practitioner to the emergency room. Pregnant woman is bitten by the dog. Can we give post-exposure? Yes, we can give. There is no other option than preventing. But in a pregnant woman, you have to get a consent that we have seen few cases where they developed neuro abnormalities like meningomyelocele. So it is always better to get a consent form that there is a remote possible of getting neurological congenital anomaly. Otherwise, there is no other go. Without giving rabies vaccine, patient would have been succumbed to rabies. So it is always better to give. Infants, yes, we can give same dose. ARV can be given to the child with chickenpox or measles. Yes, there is nothing harm in that. We can give. A patient taking anti-rabies vaccine can donate. Most of the blood banks medical officer are refusing to bleed the patient until they complete the entire rabies vaccine, and they have to wait for 30 more days to donate. But there is no harm in donating the blood. Can we interchange the vaccine? This is a very, very important question. Many times we see most of the patients have been bitten in some other place where they went for an occupational purpose, and they'll be coming back to the home. They would have started with a different vaccine, and here that kind of vaccine is not available. Can we interchange? Many times we used to get this kind of call. So preferably no. You should not try to exchange the vaccine. Try to get the same vaccine. If it is not available, then you can go for the same protection. That is, if it is a human embryo or human cell culture or a chick cell culture vaccine, whatever the vaccine which has been manufactured, same try to put, but don't interchange. Okay? Is the vaccine can provide a lifelong protection? No. If vaccine is accidentally kept in a freezer, can it be used? No. Once it is frozen, it loses its potency. Don't use it. Okay. This is a case. A 28-year-old married homemaker presented with the complaints of sudden onset of increased sexual desire and multiple orgasm for 2 days. She requested her husband for increased sexual relationship and reached multiple orgasm. Frequent intercourse never noticed during their 8 years of their married life. Had an altered sexual behavior became a significant source of stress. Consulted a gynecologist and physician. Nothing helped her, so they came to our hospital. There is no history of any drug intake. Systemic examination was within normal limit. They had done a battery of tests. Everything was within normal, including the hormonal assay. Everything was done. Seen by many specialty. No active intervention. So they admitted in the emergency care after 24 hours. Are you able to see the video? Are you able to see the movie? Video clipping? At this juncture, I like to thank my mentor, Dr. N. Balamurugan, who was seeing this patient. And the patient was admitted in the emergency room. We kept over a day. And next day morning when I came, my staff nurse was very irritable. Patient was comfortable, but the staff nurse was very irritable. I asked what happened, why you are having an irritable look. Then the staff told us, our night I didn't sleep. This patient was repeatedly asking me to switch off the fan, very specialty. Then that gave a clue to me. When I started fanning in front of her, she had a very panic look. So what is this? Yes, this is aerophagia and hydrophobia. So this is a classical case of the rabies. Actually, on the history, it was bitten by a puppy 2 months ago. MRI brain done showed mild hyperintensity signal changes, and the cardiac nucleus was showed changes. The PCR for CSF, saliva, and skin biopsy from the nape all confirmed the rabies. The patient died. So our experience, dogs under 1 year of age. That's very, very important. I'm a wounded soldier. I lost my cousin because of rabies. I had a bite. Immediately, my cousin went to a doctor. They told that it's just a scratch and by a puppy, nothing will happen. You go. They didn't vaccinate. So after 30 days, he died. So most of the bites occurs between 1 to 9 p.m. Men are bitten more than women. There's biphasic more in summer and winter. 5 bacterial isolates are identified in our thing, and patient has to be given the prophylactic antibiotic. Otherwise, this bacterial isolate can cause harm. Till now, almost 16 cases have been reported from our side. This is a case file. A 55-year-old female was brought history of cat bite 2 days ago, fever and pain. So, what do you want to do here? Any guess? Any guess? ARV, TT, antibiotic, cat fever. Okay. It is not exactly cat scratch fever. This is entirely different. It is a bite by the cat. Cat are very notorious. Okay, we have read only dogs are notorious to cause rabies. We have seen 4 cases of rabies because of cat. Okay, so any cat bite, please vaccinate with this. Recently in Tamil Nadu, we had one patient had a cat bite, developed rabies, went to a government hospital, admitted in a strong room, isolation ward. Then he had strangulated and died. Okay. Women are more likely to get than the men. 63 bites are in the 63% of bites is from our center. Hands and finger, notorious to cause very high thing. Even the patients on extreme age, diabetes, and other things, they are more prone to develop this. 16-year-old male brought to the emergency room with history of monkey bite. You can see 2 bites. Actually, he went to a temple that's nearby. It's called Chenimalai, where there was a monkey was there. He was carrying some fruits. Monkey has grabbed and had a bite. So what do you do now? TT, ARV plus antibiotic, or wash the monkey for 10 days. Option 1 plus RIG. Option 3 plus acyclovir. Which you prefer? One, TT, ARV plus antibiotic. Option 1 plus 3 RIG. Okay. Somebody is telling 4. Why 4? Any special reason? Why 4? Any special reason why it is 4? Actually, 4 is right because exposure to B virus by the monkey bite. Okay, fatal encephalomyelitis in human is due to monkeys. Okay, so herpes simplex virus infection is similar to that HSV. So acyclovir works very well. So prophylactically, we need to give acyclovir in a monkey bite along with your consent. This is a bear bite. We have the forest near Satimangalam. We get bite. Wildcat. This is a cat. Tiger bite. We have treated. Okay. This is a very common. 22-year-old lady was bitten by her husband, not giving money to drink. So bitten. Okay. Human bites are very high at the risk of infection. Common in fight males, especially in the weekend. Okay. Because of all the task bars, we used to get a lot of patients. Significant injuries, you have to explore. The wound should be thoroughly irrigated and it should be left open and should be immobilized. Antibiotics should be started as early as possible. Please remember that without taking any x-ray, please don't suture the wound. Okay. Once the finger are extended, the tendon retract and seal the contaminated wound. The deep laceration to the bursa capsule will go and produces severe infection. Okay, joint space septic arthritis have been seen. Tendosinovitis we have seen. So this is very harmful. Please remember the mnemonics helicopter. Okay, for any bite, okay, any animal bite, history, proper history, do a thorough examination, liberal cleaning, irrigate the wound, consider culture if you think that it is more possible to get infection, do operative debridement, prophylactic antibiotic, TT, elevation, assess for the rabies risk. So this is a summary of an animal bite commonly we see here. So except rat, okay, except rat and the human, no need to give rabies vaccine. For all other wild animals, okay, today we admitted a patient with horse bite. Okay, so where you need to give rabies, okay, rabies vaccination has to be given. So this is a 60-year-old diabetic female brought to emergency room in an unconscious in her field. Okay, you can see this lot of small bite mark. Patient is totally unconscious. Initially we thought it is hypoglycemia, but it is not hypoglycemia. It is due to hand bite. Patient because of heat had some giddiness and fall, and then had a multiple bite. Hand bite is produces severe intense pain. Okay, it produces severe muscle damage and ultimately leads to acute kidney injury. So proper hydration and alkaline diuresis is needed. Some patients we have taken for hemodialysis also because it contains formic acid. It damages the muscle. This is due to VAP sting. Okay, VAP sting. It's a single or multiple VAPs can bite, but this will produce a severe swollen face. There can be a chance of airway threat. So you should be competent in handling the airway obstruction. And this is a case 8 called for rescue. A 65-year-old man, multiple bee stings bitten, they told. So when I went, this is a picture I took from my ambulance. Okay, you can see a lot of swarms of the bees are there. Not exactly this, but we call the help of fire service people to spray the water and then we reached. This is a patient. You can see multiple stings are there. Okay, so this has all been removed. How to remove? Any idea how we will remove? If we go through the all old textbooks, they will tell keyhole technique. You should not rub the sting. Okay, rub the sting. This will produces more venomation. So we have to use the bee stinger. Actually, it is not tweezer or any other thing. We have to remove it very early as possible, as early as. Okay, my mentor Dr. NBM used to say, speed thrills and method skills. If you are delaying in removing the stings, then this will produces more toxicity, more muscle damage. So the things has to be removed as early as possible, and you can keep ice pack to diminish the edema and delay the venom absorption. And don't give NSAID is like diclofenac or pyroxicam. You should not give. Preferably tramadol or any other opioids, analgesic can be given. H1H2 blockers, steroids, and TT has to be given. There are few cases have been reported. Tetanus has been reported following a honeybee sting. So it is always advisable to give TT. Even a single sting can cause airway threat. So you should be very confident in handling the airway. So treatment for any anaphylactic reaction or toxic reaction, then you can give adrenaline is a drug of choice. 0.5 milligram intramuscular for the adult, and for the pediatric it is 0.01 milligram per kg intramuscular in the children. We have to repeat 2 doses every 5 to 10 minutes if hypertension is persistent. But mostly within 2 doses they will settle. And this American Heart Association has given. In addition to adrenaline, you have to give antihistamine to reduce the second phase or a delayed phase of anaphylaxis, followed by hydrocortisone. Okay, this is to maintain the state and prevent the rebound. And very importantly, in a patient with beta blockers, especially who are taking atenolol, okay, they will not respond to adrenaline. Okay, we should give glucagon, otherwise this will not work. This is a 16-year-old male brought to the emergency room with history of scorpion sting just 30 minutes ago. So what do you want to do? You want to admit, or we can put some medication and send? Any guess? Somebody told admit, somebody told we can send OP, observe for 24 hours, admit. Actually, in my ED, I used to get at least 15 to 20 cases of scorpion sting in a month. Okay, minimum. I'm just telling you. If every cases we admit, then it will be a big issue, and they will tell the doctor is trying to loot the money for even for a scorpion sting. So we need to have certain criteria: which patient to admit, which patient to observe, which patient to send home. Okay, so we'll see how it is. The severity of the sting, it depends on the size and degree and agitation of the scorpion, depth and the site of the sting. Fleshy areas are more harmed than the bony areas. And again, it depends on the victim's health, general condition, age, and size, whether it is small, puny, or a infant, or a pediatric, or so old age, amount of venom. Actually, it can split the venom up to 1 meter. Okay, so when we do a LD50 comparison, as you well know, the LD50 is what is the lethal dose of 50%. It is almost equal to king cobra. Okay, both black scorpion and your king cobra has same LD50. Why then it is not causing more death? Because the quantity is very small. Otherwise, this will kill even a big elephant. Okay. So if you want to do a local block, try to always mix with the lidocaine and bupivacaine. It gives an excellent pain relief. So repeated pain indicates there is an improvement in the systemic circulation. Prazosin is an antidote. It is 30 microgram per kg body weight. Thank to Dr. Bavaskar, who identified this prazosin as a physiological antidote which counteract the autonomic storm. And remember that even the blood pressure is 80/60, you can give prazosin. But one important thing, that patient should be in euvolemia. The patient is in dehydrated state, you should not give prazosin. First, you give a fluid resuscitation, then go. And the patient is in hypotension, presenting to a hypotension. Usually, they present with hypertension, and if they present with a depletion, this is due to catecholamine depletion or prostaglandin pathway activation. Steroid, it has no role, but our forensic colleague says that doing an autopsy, they have seen adrenal hemorrhage, so it may use, but preferably we don't use steroids. Dopamine, no role at all. Anti-scorpion venom, I have very limited experience. Only 5 patients I have treated with anti-scorpion venom. They improved, but without a anti-scorpion venom, we treat the patients, they improve very well. Okay. So JIC is a very good drug for maintaining the patient in the ICU. So we have a scoring system. It's called as a Gokulam risk assessment in scorpion sting. If everything has, we give 1 point. If it is more than 3, then we'll observe the patient in the ED. If it is more than 5 at the time of presentation, we admit the patient. If more than 6, the patient will be directly go to the ICU. Clear? So age, time of presentation, vomiting, both extreme ages will be taken in consideration, and early presentation, delay presentation, vomiting, agitation, sweating, priapism, hypotension, chest congestion. Anything is there, majority of them, then the patient will be admitted. Okay. So this is a WHO's picture showing world burden of snake envenomation. You can see the yellow part is all contain snakes. In Russia, it is very difficult to see a snake. Mainly in Southeast Asia and a part of Australia and New Zealand, we see a snake, and African countries we see. And in South America, in a certain part and Central America, we used to see. This is a very old data from a WHO. Subsequently, it has been changed. And in Asia Pacific region, we see 1 lakh of this patients are dying due to this snake bite. In India, approximately 216 species are there, and out of which 52 are poisonous. The annual fatality rate in India, it's very limited, and it is just a tip of an iceberg. We are getting, because now it is notifiable disease. In last year, they are saying that it is around 46,000 people have been and died because of a scorpion sting. So big 4, you know that cobra, kite, Russell viper and saw-scaled viper are big 4. But in my place, we are seeing another special thing is called as hump-nose pit viper. And I am also seeing another snake, which is the green pit viper. Why it is important? Because this is a new species. Most of the time, they consider this as a non-venomous. Or you can see this. This is a green pit viper. Okay. Because in both pit viper, the anti-snake venom which we are using is totally ineffective. So you give hundreds of vials, they will not show any change in the coagulation profile. So, and again, it is difficult. Many times I have seen that the junior doctor are asking the patient which type of snake bite and where is the snake, have you brought the snake. Again, disposing the snake is a big challenge for the treating physician. Just like that, we cannot put it in the dustbin and throw it. Okay, it is similar to a biological part. You have to discard properly as per biomedical waste regulation. So better we can show the picture of the snake, and we can ask, or we can go by the clinical picture rather than the type. WHO has categorized with the various syndromes. Syndrome 1, local swelling, bleeding disorder, it is viperidae. It may be a Russell viper, or it may be a pit viper, or it may be a saw-scaled viper, whatever may be, the pit viper, the viper. You can see swellings. Okay, some patients we see a local swelling, some patient we see ascending swelling. You see, this is a bite area. Gradually, this patients ascend up to here. The swelling is there. Okay, so ascending swelling, it's again a sign of envenomation. In few patients, they will not have initially any swelling at all, but they will have a blisters. Developing blisters is a subdermal necrosis of the skin due to the venom. Again, it is a sign of envenomation. Venom-induced coagulopathy, you can see a lot of bleeding. This is commonly seen in a viper bite. Gum bleed is the first site to bleed. Subsequently, you can see a lot of other bleeding. Syndrome 2, local bleeding, bleeding disorder, shock, renal failure, not responding to ASV. Again, it is a hump nose pit viper or a green pit viper. The patient having a local swelling, bleeding disorder with the ptosis, external ophthalmoplegia, facial weakness, then it is Russell's viper, but it will respond to ASV. Syndrome 3, local swelling, ptosis, external ophthalmoplegia, facial weakness, then it is cobra or king cobra. Syndrome 4, no local swelling, suspicion of fang mark, bitten on the land while sleeping in the indoor, patient developing ptosis, external ophthalmoplegia, facial weakness, then it is a crite. You can see this patient. This is a very interesting story. I will tell you in subsequent slides. A dark brown urine, renal failure, paralysis, bitten on the land, then it is a Russell viper. Russell viper is a very nasty. You can see this patient had a bite, so bleeding is active bleeding, oral bleeding is there, swelling started swelling, and hematuria is there. So this is very, very nasty in handling the Russell viper. So this is an important picture. You can see that summary of cobra, crite, Russell viper, saw scaled, and hump nose pit viper. And you can see all the S categories can be taken into the consideration, and no, we have to carefully exclude it. So this will help you to save the snake bite victim. Clear? Any doubt till now? I will answer. So protocol for managing a snake bite management, you have to establish the envenomation both clinically as well as laboratorily. So clinically, the patient, as I already told, should have any neurological component or hematological component. Then the patient should have increased 20 minutes whole blood clotting time, or prothrombin time is increased, APTT is prolonged, renal function is altered, urine analysis shows some hematuria or cast, then we can think of this. Anticholinesterase therapy, yes, definitely it is useful if you are in a remote place or a resource limited area, then you can give anticholinesterase therapy, but this works only for cobra and not for any other snakes. Presynaptic will not work, only postsynaptic this work. And this will be a bridging gap for your ventilation. If you are confident and you are able to intubate the patient and provide a mechanical ventilation, you can do this, and then no need for this anticholinesterase therapy. Then you have to administer full dose of ACE. Now the question comes, what is a full dose? Okay. So we are using a polyvalent antivenom. So we no need to know what type of snake is bitten, but we normally rule out a hump nose viper or pit viper, especially if the patients are coming from the Satyamangalam forest or Kalrayan hills, or the patient is from Kerala, then we think of hump nose pit viper. Otherwise, we treat them as consider that they were bitten by a big four. Okay. So the test dose you want to give or not? It's a foreign body. It produces a lot of anaphylaxis. Yes or no? Yes. No. Yes. No. Yes. Yes. No. Why no? It is a foreign body, no? Foreign material produces severe immunogenic reaction components. Delay in time, cost to life. Okay, good. Anyhow, we are going to give ASV if indicated. Yes, if you are giving ASV, if the patient develop anaphylaxis, what you will do? It is a crime. But test dose is not necessary because there is no alternative. Whatever maybe I have to go to UASV, so no need for any test dose. But in olden time, it was the time where they used to check the test dose, and then again the patient develop anaphylaxis after that. So complications can be from acute kidney injury to paralysis. You can see we have seen a patient with amputated part having a snake bite. Immediately he is a carpenter, just with a chisel. He just chopped and came with this. So it was very tough. One side we are neutralizing the venom, another side plastic surgeons are doing a microvascular surgery to reimplant. Multiple nicks. Okay, this is bitten by a non-venomous snake, but the patient presented to us with a septic shock, staphylococcal infection, toxic shock syndrome. So here, no need to do all these things. This is one of our latest paper where the patient had a tongue bite in the snake bite in the tongue, and immediately it was chopped and then came to us. It was very hard to save this patient. The new tool we are using Engel. Engel is a neutrophil gelatinase associated lipocarpine. It helps you to prognosticate the patient in a Russell Viper patient. Whether this patient is going for renal failure or not, we can predict within 2 hours of our bitten time from the bite time. Okay. Another important tool is phospholipase A2 level. We are routinely measuring. So this will give a clue whether this is bitten by a venomous snake or non-venomous. So this is one of our paper. We got 7 awards for this paper. This is a neutrophil paper identifying as a biomarker for acute kidney injury. And this is for renal replacement therapy. So when the cutoff value is more than that, we came to know that the patient they are going for a dialysis. So phospholipase, again, this is another paper. We can be able to identify whether they are immediately, we are able to do that. Okay. And we have seen various silent inflammations like convulsion, unconsciousness, hypertension. This is one of our paper we published. It was a severe hypertension following a Elapidae bite. Okay. And very commonly we come across patients with a snake bite and having an hypertension, but they don't know that this is due to a snake bite. So few other symptoms where we see persistent vomiting, abdominal pain, enlarged tender lymph nodes will be there. Okay. And this is another interesting case. This was a panic call from a surgeon colleague. He was telling that, sir, I operated a 21-year-old female for acute appendicitis under a spinal anesthesia. Procedure was uneventful. Now she is going for a respiratory depression. I am suspecting there could be a complication in the anesthesia due to high spinal shifting for the ventilatory support to a center. On an examination, I thought patient was drowsy, arousable, afebrile, no pallor, nothing. Other symptoms, vitals were stable, hemodynamically stable, and saturation was 85%. Admitted in the ICU. While removing her stud, she was complaining of some pain. Staff nurse noticed swelling, warmth, and tenderness in the right ear. You can see the auricle pinna is little swollen than the normal. On further inquiry, she is the daughter of a district superintendent of police, woke in the early morning with an abdominal pain and vomiting, taken to a prison medical officer. So after examination, prison medical officer told it could be acute appendicitis, sent to a local hospital. Because she is a daughter of a superintendent of police, and immediately she was taken to a operating theatre for an appendix. When I asked surgeon told her appendix was not inflamed, though I went inside, so I removed the appendix. She was staying in an SP bungalow, which is surrounded by the dense tree. On searching her room, we could find a 2 crite. Okay, you can see that 2 crite was there. This is a ptosis. This is not due to high spinal. There is nothing terminology called high spinal. So acute abdomen in the early morning. Okay, please remember snake bite as one of your differential diagnosis. This is a kid came as an acute appendicitis. I am examining and I am doing a broken neck sign. Okay, asking the patient to lift the neck. The patient is conscious, if they will try to lift, or if the patient is irritable, not able to lift, then we can do this. The patient will not be able to pull. So this patient, same patient, after giving ASP, 10 vials of ASP, you can see he is sitting. Okay, crite is a nocturnal creature. They are painless, wake ups in the early morning, mimics like an acute abdomen. This 45-year-old homemaker had a snake bite, taken to a native practitioner, gave some medication. She became unconscious, taken to a local hospital, diagnosed as a brain death, confirmed in a big 3 corporate hospitals. Then taken to the home, no response, only breathing movement was there. So they came to our hospital. I was not aware of all these issues. So I was telling about ventilatory support antivenom. The entire village was looking very suspicious on me. One person was known in that group came to me and told, "What sir, I had a very high regards to you. Are you trying to replicate Ramana in our hospital?" Ramana is one Tamil movie where they ill-treated the doctor, saying that they are treating the dead patients just to loot the money. Okay, so I discussed this matter with my management. The pupils are totally dilated. Okay, you can see, and my management told, if you are confident, go ahead. We will treat the patient free for 24 hours. Then I told the family members, we will treat it for free. If the patient responds, you pay for it. Otherwise, you can enjoy the free. They were very happy. They want to know whether the patient is improving or the patient is deteriorating. Something has to be done, not just status quo. So we intubated the patient, given ASP. Luckily, movement seen after 12 hours, became conscious within 24 hours and extubated. After extubation, the patient was telling, I was crossing my finger. Every doctor who are examining telling that I'm dead, but I'm not able to say and communicate with you. Luckily, now I have done. So how I get this confidence? This case is called as a logged-in syndrome. Okay. So we are trained and taught in our medical school to do a Dulce phenomenon, horizontal eye movement, but we are not ever doing a vertical eye movement. Here there will be a preservance of vertical eye movement will be there. Frontalis muscle movement will be preserved. And if you have a anesthesia colleague, you can ask them to do a train of 4, median nerve stimulation, that will be there. You can see this is a patient. When I am telling to look up, see, she was able to lift. So this horizontal movement will be present. So various guidelines and other things we have given. Logged-in syndrome in a post-snake bite, brain death, handle to care. That's a caution we have done. So before concluding, this is an idle. Okay, MUL 847. This was there for 1971 to 1994. For 23 years, she donated 4,520 liters of blood. Okay, so based on this, they produced 35,000 vials and 3,500 lives have been saved. Just a mole and an idle can able to save 35,000 of people. Actually, this is from the place where the venom has been manufactured. Okay, you can go there. There is the tomb vacant. You can see this picture. As a human, that to a doctor, let our thoughts and deeds be the catalyst for the better tomorrow. Thank you. Any questions? I'm happy to answer. Somebody has asked, do you need to give paroxetine for all cases? No need. Actually, if you are seeing a blood pressure is little higher, 130 or 170, then 130 or 140, then we can give. Or if you really think that this patients may develop pulmonary edema due to hypertension, then we can give. Autonomic storm has to be neutralized with the paroxetine. Any questions? Antibiotics in a snake bite, yes. We have done a study and we found you have to follow your local antibiogram. Here we give common antibiotic like ceftriaxone or cefoperazone sulbactam is sufficient to handle. And if the patient has been treated elsewhere and coming, then we have to give a gram-positive culture. Maximum how much vials of ASP can be given for hematotoxic and neurotoxic. Hematotoxic maximum 30 vials and neurotoxic only 20. If the patient comes late only with cellulitis, can we give ASP? So this is a very wrong practice. Most of the time, as I already told, patient should have both clinical as well as lab has to be showing envenomation. Just with the cellulitis, no. In case of suspected snake bite, can we give ASV? Sir, again the same answer. Both clinical and laboratory should show the signs of envenomation. Otherwise, no. Is ASV is common for all snake bites? Yes. It is a polyvalent. We can give. Subcutaneous adrenaline preventing anaphylaxis of ASV. There are studies from my center where I have done Sri Lanka. We have done 3-4 phases. Okay, one patient received adrenaline subcutaneous, another patient received intramuscular, and then they started low dose, high dose, normal dose. All we have tried. And importantly, if you observe the type of anaphylaxis, it's just like a pyrexial reaction. So one important thing is wash the hand. Advise your staff nurse to wash the hand, put a glove, then take ASV and dilute it. Because when we are diluting, there is more chance of contaminants are entering into the IV saline, then it produces reaction-like reaction. After following this strict precaution, we are not seeing any case of anaphylaxis. We are not routinely using prophylactic adrenaline. Cat 3 dog bite with a deeper wound. Should we suture after doing an X-ray? Adequate wound debridement to prevent? Yes. It is not mandatory, but if you feel that there is a cosmetic reaction, agent is there, then if there is any wound risk of infection is there, then you can give rabies immunoglobulin and then you can suture it. The suture should be very loose. Both lab and clinic should present to give ASV. Yes. If it is hematotoxic, yes. If it is neurotoxic, clinical is sufficient. ASV should be given as bolus or infusion form. It is infusion form. 10 vials of ASV is given. It is diluted in 250 to 300 ml of 5% dextrose, and it will be given over 45 minutes. And then you have to wait for 6 hours to assess how the PTA, PTT or your clotting time is there. If it is coming less or if it has become normal, then we can give off the dose. If it is not returned to normal, then you can give another 10 vials. The maximum of 30 vials. Will ASV work for black mamba? No. Infusion duration start initially at 45 minutes, first dose, and then every dose should be there for 5.5 to 6 hours. How many vials of ASV for non-poisonous snake bite? No. ASV for non-poisonous snake bite. Only venomous snake we have to give ASV to neutralize the venom. Otherwise, no need. Only cellulitis, ASV not recommended. Yes, yes. Only cellulitis, no ASV. Any other doubts? Role of cloxacin, yes, you can use cloxacin in any infection. It is a good antibiotic and less abused. So we can use cloxacin, nothing. But one important thing is the oral cloxacin or IV, it is now the cost is increasing and getting very scarce. Getting scarcity is there in getting. And otherwise, we can use cloxacin. Is it preferred over ceftriaxone? See, cloxacin is not freely available in our center, so we use either ceftriaxone or cefoperazone sulbactam based on the wound and other site. If it is necrosis and other thing, managing wound in the snake bite itself is a separate class. Okay. Role of calcium gluconate in a snake bite, yes. Few centers are using for the crite, and we are also doing an international clinical trial on calcium gluconate in a crite just to regenerate it. Still, based on the interim analysis, we are not getting much confident to say that yes, it is definitely useful. What is the ideal time to start ASV after poisonous snake bite? As early as possible. What questions can we expect in upcoming exam? Sorry, I don't know. I'm not a question paper setter. Dosage of calcium gluconate. Calcium gluconate is we have to give 10 cc over 10 minutes. We can give 10 ml over 10 minutes. Okay, main indication is hyperkalemia. In a cried bite, they are saying that it is useful and we have to wait and watch. Any other questions? If no other questions, thank you. Good night.